lot of advanced technologies. I've had the honor to work with him for many years. He's definitely a science-driven mind. He trained under Ray Yuckna at University of Colorado, where he went to dental school, and he's got some pretty interesting information he's going to share that he's been working on with the PerioLase over the last few years. Thank you, Doctor.
Thank you. Good afternoon. As you see, I'm a big fan of Sir Richard Branson. The concept is like every risk is worth taking as long as it's for a good cause and contributes to a good life. As he well said that. It said if someone offers you an amazing opportunity and you're not sure you can do it, say yes, and then learn it later. That's what I did. So my introduction to Millennium was thanks to Dr. Yuckna, who's my mentor and my friend who just introduced me, Anthony. This is, I'm talking 5-6 years ago when I started to learn the concept of lasers treating periodontal diseases. So as I wanted to be the Top Gun dentist, I looked at this machine. He brought it to my office, rolled it in, and said, okay, it does a lot of different things. And I was like, it looked something like this to me, Wall-E, and it was very interesting as a concept. Or it, I guess the later trends is BB-8, if you watch Star Wars, an android, so it's, or droid rather. And that's pretty much how this machine looked to begin with. I was definitely intrigued, and again, when I started to learn under Dr. Yuckna, I learned more about it. Then, as I started to get involved into LANAP and LAPIP procedures, I started to look at the other value-added advantages this technology had to offer. So there's pediatric dentistry, cosmetic dentistry, removable prosthetics, fixed prosthetics, periodontics, oral maxillofacial surgery, and what really interested me was the TMDs. Very complex, not understood well, and was wondering, what can we do to have technology help us treat it better? And there were more questions than answers, and you know, as always, when we start training in LANAP, we would be like, oh, okay, so is this machine going to do everything that we hope for it to do for our patients? So as I started to get into more and more of the information, I decided to go into UCLA. I got my specialty in TMJ and orofacial pain. Wanted to understand the basics first. So that's me, Sathish Palayam. I went to University of Colorado School of Dental Medicine. The good thing about that school was there's really not many specialty programs there, and we got to do a lot of different things. So it was, and again, if this is my email address, if you have any questions, feel free to email me. So my mission for today is to take control of what we own. I understand we have different perspectives about the TMJ itself, and you know, we got to learn more about it, but I think we have a good control over the system. We understand it better because it works within our you know, different algorithms that we would try to create in the mouth, and we need to understand this so that we can treat it effectively. So as we understand that most of the conditions are inflammatory origin, so that we got to understand that, okay, there are medications, there are drugs out there that can be treating these conditions, but what if we use some kind of non-invasive techniques to treat this kind of conditions? So we can diagnose, manage, treat TMD and orofacial pain in our offices, and this will really help us get better care to our patients. We can stay as the general contractors for our patients, because a lot of times they get between the primaries to the neurophysicians, to neurosurgeons, to oral surgeons, to, and they get lost in between all of this. So we can do this. And our mindset is that the most common objections to adding dental treatment avenues and technology to our service mix is the fear of failure. But we understand the practice landscape is changing, and that's why it's very critical for us to get more trained, more knowledgeable, and provide just better care for our patients. So how do we mentally get prepared for this? We have dental school as our basic foundation. We have the evidence, research, the white papers, and then of course, the training that we can take. And the biggest thing I did was when I joined Millennium as one of the LANAP trainees, that was one of the most amazing experiences I've had. and it really taught me a lot. Met a lot of great people who have had immense knowledge and experience, and that really helped me be a better clinician today. So thanks for that. Or is TMD very complex? And the answer is yes. And it's important for us to understand the complexity of it and what are our limits and how far we can go in treating these conditions. So guess what? We have this guy, and if you don't have it, please go get it, because it's one of the most useful tools you can have. And again, if we have this in the armamentarium, it's great. We have won half the battle, because it does provide a lot of different volumes of work we can deliver to our patients. If you don't have it, go get it. There are people back there who could help you with that. So this is the classification of orofacial pain. That is complex, really complex. So in order for us to understand the categories of where we can stay and treat patients successfully is pretty much the musculoskeletal, because once you go further ahead, there's more morbid situations, more complex problems. There's more involvement of vascular system, neural systems. So primarily is where we're going to stay here is the musculoskeletal. The 7 rhythms of orofacial pain could be tooth-related, joint-related, muscle, sleeplessness, depression, any form of headaches. So we need to understand this and kind of come to an idea as to what really is the cause or the underlying cause for these problems. So let's look at a simplified version of this classification. And as you see here, it's very musculoskeletal. There's muscle problems, there's joint mechanics, and some kind of inflammatory response as far as the joints with systemic involvements like arthritis, rheumatoid arthritis, capsulitis, and so on and so forth. I'm not going to go to the depth of all these things. Again, some of my slides can be very information heavy, and I'm just going to skip considering the time I have here. So please, I ask for your apologies in advance. Okay, so diagnostic categories are, TMD is basically an umbrella terminology. You know, if a patient comes and says, oh, he's got TMD, that's just an umbrella term. It has got multiple things underneath it. One is the internal derangements, the orthogenesis, and the myogenesis conditions. And as we know, and we start to get into the depth of all these things, we also look at how can we treat these conditions in a simple format. A lot of people will say, okay, let's get an occlusal guard in there. Maybe that's going to help. But did we understand it better? So that's why I'm just going to kind of briefly explain what these disorders are. Again, this is where we're going to pretty much stay on course here. Myogenesis, which is myalgia, myofascial pain, myositis, trismus, spasm, contracture, and claudications. Now, how many of you do biostims here? Anybody? 1, 2, 3, 4. What's your experience, if you don't mind sharing? Like, what's the pain relief? What kind of pain reliefs, the duration of time, and everything? Can you please share your experience?
So traditionally, I use it after every one of my LANAP cases. Patients come back feeling great. They're not tired when they're open. I've done a couple of myofascial issues. Just did a couple thousand joules into a big muscle. Tend to get some nice relief from my patients.
And the patients responded with good relief?
Yeah, it usually takes a couple rounds over 2 or 3, 4 days.
That is correct. Anyone else wants to jump in? Any other? All right, so let's proceed here. And again, musculoskeletal, neuropathic, and neurovascular, which is migraine. Now, that's why it's important we understand that, there are limitations in what you could treat them with laser split primarily. So we know the muscles of mastication, the masseters, the temporalis, the medial pterygoids, the lateral pterygoids, and the digastrics, and all these are muscles. So when there's myositis, there's inflammation in these muscles, and we could treat them quite successfully. And I've done more than 45 cases I've followed up for the last 4 to 5 years now, and consistently had very good results. Of course, it's never 100%. There's always other problems that are associated with it, like habits and medications and compliance and so many other things. But every time a patient comes into the office with a lot of pain, in a pain scale of 0 to 10, maybe a 10, I I can bring that pain down to 2 or 3 in a matter of minutes, 12, 15 minutes, and the patient leaves the office. No Percocets, no ibuprofens, nothing. And they will be quite happy leaving the office almost pain-free. And I've been able to repeat that. I've been able to reproduce that, and that's great news. So when we talk about, of course, this is the general medical history that you got to take, which is very important. My important part here is that you got to understand, trying to get the laser here. Okay. The most important part is that you got to see what you're treating, and you don't want to treat strangers. So you got to have a very adequate medical history. You got to see if there's photophobia, phonophobia, there's nausea, is there vomiting, is the pain pulsating, non-pulsating, is it aggravated with physical activity, any autonomic features, and any red flags. And that's why it's important that you categorize and you understand what you're treating. In the SNOOP 4 red flags, you got to understand the systemic and other factors involved in this condition. Neurological involvements, the onset of the pain, the older age of onset, more than 50 years. Again, there are other associated systemic conditions, prior headache histories, new or different headaches. Again, you've got to look at systemic secondary factors, which are fever, chills, night sweats. And I'm really going very quickly on these because I want to go to the most fun part again. So just excuse my urgency on this. Then the neurological signs and symptoms, which again, you got to look at global neurological symptoms, possible secondary causes, which could be neoplastic, inflammatory, infectious, vascular CNS diseases, just to understand what you're really trying to look into here. And the onset again, is it sudden, going from 1 to 10 to 10 to 10, like really quickly, that means you've got really underlying systemic factors that you want to stay away from, and you want to have your friends treat those kind of conditions. Older age of onset, possible secondary causes are neoplastic, inflammatory, giant cell arteritis, which is very almost a medical emergency. So be aware of these things. Patients expect you to be aware of it. If you can't treat them, just show them the right direction. Okay. Now, as we start to think about all these different things, our heads start to spin as to, okay, what are we treating here? As I said, we all have to focus on one thing, and that's myogenic and musculoskeletal, and there's where our lasers would really give us very good results. Now look at the incidence and awareness. So there are musculoskeletal and neuromuscular conditions. They average about 15% of adults and increasing, with a peak incidence at 20 to 40 years of age. It's twice as common in women than in men. It carries a significant impact on quality of life, as we all know that. Symptoms can range from mild discomfort to a lot of pain, including limitations of jaw function, trismus. Common symptoms include jaw pain, as I said, ear aches, headaches, and facial pain. And the etiology is there are different factors involved here. So we have biologic, environmental, social, emotional, and cognitive triggers. So again, we're not just treating teeth. We want to make sure that we are treating the whole patient. And that's very crucial that we have an adequate medical history that we collect from our patients. So that's pretty much what TMD is, pretty complex. But we can go back and understand that if we go back to our resources, which are dental schools, we'll not skip our occlusion classes anymore. We will not, we'll go to residency programs where there's more detailed training, find mentors, like I found one in Ray and was really helpful. Get into dental meetings like what we're doing today, and the study club. And I did gain a lot of information and knowledge from the LANAP study clubs. It's very, very useful, a lot of information on those things. Or basically just ask, when we ask, we find a lot of information out there. It's just unbelievable. So when we look at the management strategies in orofacial pain, education and self-management, this is very key. You want to get your patients involved in getting better at their symptoms. We look at their behavior, we look at possible pharmacological therapies, physical therapy, orthopedic appliance therapy, and the lowermost is LLLT and HLLT. LLLT is the low-level laser therapies, and what I'm going to talk about is HLLT, which is a high level. And we are talking about an Nd:YAG laser, that's the PerioLase, working at a 1064 wavelengths. It's pretty high in energy there. Okay, so the goals are to reduce pain, reduce adverse loadings, restore function, resume normal daily activities, and it is possible if you understand what we're treating. So the educational self-management, again, myofascial protocol, avoidance protocol, stretching, exercises, all this comes or encompasses under one important thing called as a physical medicine protocol. A physical medicine protocol is basically physical therapy, exercises, yoga, meditation, you name it. This all helps in better behavior management and better lifestyle for our patients and proper physical therapy, because all these things reduce pain, inflammation, strengthen and promote repair and regeneration. And that's what lasers really do. They help in repair and help get a better lifestyle for our patients. If you look at the pharmacological therapies, you look at topical applications, you got lidocaine patches, then you got these bunch of medications that I'm not sure how many people in this room are comfortable giving, except my previous speaker, a oral surgeon, much more trained than I am. But I would probably refer those patients back to my primaries, the patient's primaries. But I can do much better than that, because all they're trying to do is using cascades of medications to control those symptoms. It is just management of care. It's really not treating the problem. So I hope we all agree to that. So again, same pharmacological therapies that they all get prescribed onto. So then we talk about occlusal appliances, and we have a little bit of information on that. It helps prevent or avoid the aftermath of attrition, cheek ridging, all those little things. And it impacts symptoms more than tincture of time, because that's pretty much what it's doing. It doesn't stop a person from grinding his or her teeth. It's just protecting the aftermath of those consequences or those habits. Now let's talk about the real stuff. The power of PerioLase. And how do we manage TMD? Now that's the machine that I've been using for almost 5-6 years now. And that's the handpiece that comes, you can go to their website and you can get it. It helps in focusing the laser energy onto the sites you want to treat. Why PerioLase? Well, the wavelength is 1064, and more importantly, it's the power meter. So the power meter helps us calibrate the amount of energy that you really could put onto those muscles to treat those muscles or those problematic muscles. So it's basically an inflammatory process, as we understand. The severity of the injury, the vascularization of the affected zone can give us information on the magnitude. So the more the inflammation, the more the pain. And that's when you start calibrating the amount of dosage, the amount of visits the patient can come to your office to treat. And you can put a certain protocol together, and which we did. I worked with a physicist, we put a proper treatment protocol together for treating our patients. So we studied over 45 patients, out of which we had almost 95% success in treating those kind of symptoms. So we're talking about cellular injury and the recognition of receptors. So this is going into real chemistry and the pathological deterioration of tissues, and that's where we're trying to get to, and that's what our machines have been doing so far. This is the cascade where there's destruction, you treat or you eliminate the problem, or try to eliminate the problem, there's repair, and there's remodeling. That's where you come in and basically you prevent the destruction from the inflammatory process that's kicking into the muscles, and your goal is to get to repair and remodeling of those muscles. And again, there's a lot of chemistry going on here, and that's what we're going to target due to short time constraints. I'm going to skip. Again, another graphic of what really is happening here. So the concept of photobiomodulation or biostimulation got picked up from our good old science of photosynthesis, where a photon energy is transferred to the ATPs, and that's where the energy stored transports a chemical energy throughout the cell. Simple chemical pathway of different things going on. So we took the same phenomenon and talked about photobiomodulation and how does it really treat our muscles. And this is pretty much the cascade of events that happens. And the same principle was involved where we try to concentrate a lot of energy into the damaged tissues for repair and regeneration. So what are the primary effects? And this is crucial. Absorption, which as soon as you start placing that energy onto those tissues or muscles, you're talking about absorption of energy. Increased ATP, increased nitric acid, increased membrane potential, protein synthesis, release of growth factors. And if you look at the cells, there's hemostasis, there's proliferation, there's migration. So a lot of things happening as soon as you throw that energy on that muscle. Huge differences. What are the clinical consequences of that? There's relief of pain. There's reduced inflammation and edema, and enhances wound healing. And all these people who have been trying to do photobiomodulation and biostimulation with even the physical therapists, that's pretty much what they're trying to do. Again, they're all heavy on matter here, so I'm just gonna look at some of the most important ones here. So you look at the wavelength, you look at the total energy that's being distributed to the damaged muscles, and there's a proper form. That's the form we created, a protocol we created to keep a documentation of this entire sequence of events that will happen. Again, what is important was you tailor those different categories of TMDs, which we spoke about, and whether it's neurogenic, myogenic, capsular, and you want to generate the equal amount of energy onto these kind of sites to treat them. So if you look at the light dose, the total energy is 2,100 joules, and when you do all the math, which I'm not good at, it comes to about 74 joules per centimeter square. My physicist helped me put together this slide. And if you look at this on to your left, that's the printout you get from your machine. And that printout is crucial because it gives us a lot of valuable information. And the most important one is the total joules of energy that you used to basically have the tissues have the absorption. So that's what's crucial. More inflammation, more energy, the better manipulation and better treatment and relief of pain. But again, it doesn't happen on the same day. It has to be sequential. It has to be approximately, depending on the severity again, in a week intervals. Every week you have the patient come back for a follow-up, physical medicine protocol, remind them on compliance, and treat them with this basic joules. How many of you are comfortable giving Botox injections and lidocaine injections? Just one hand, two. Everyone in this room can do this. Try it on yourself. If you've had a bad day, your back is sore, your neck is sore. My mother had a fall, she fractured her arm, and they did a lot of different procedures, and her index, ring finger, no sensation. They went back, did more microsurgery on her, and still couldn't get all the sensation back. I thought, okay, I have this machine, nothing to lose. I tried it on her. 6 months later, she almost got back 75% of her sensories. Something has happened there, something good has happened there. And that's what I say, that if you can take risks that'll make different changes or brings, yeah.
How many times do you
Almost once a week, almost 6 to 8 months. Another example, I had a patient, had a jaw fracture, had a bone plate put on here, a lot of compression on the mental foramen, a lot of paresthesia up to the front, treated the patient for almost 6 to 8 months, had great improvement, started to get the feelings back in again. Another patient, third molar extractions. Of course, there are other procedures, again, surgical interventions where you can put artificial grafts to work up and generate your lost IVs. Again, great improvement. Is it going to be 100%? Probably not, but it's better and it is less concentrated versus having the whole area numb here. At this time, after about 4 months or so, the patient just has a little bit of paresthesia on the lower lip. It works. We got to trust the science. We got to trust the research. We just cannot give up. If we all say it's not going to work, and that's all we said about LANAP too, it works, but you got to do more. The more you do them, you start to see the results.
How long do you do the stimulation?
Okay,
10 minutes or
10 minutes approximately, yes.
Okay.
Yes. Yes.
Do you have any concerns with the actual disc itself? I know there's reports that if the ATI at that rhythm hits the disc, it can relax or loosen the disc, and the negative side effect.
That's a good question. And yes, we keep an eye on that. And sometimes I really take a CT prior to treating these kind of conditions. But yes, you want to be very careful when you're focusing the energy right on the joints. You got to be super careful. Again, it's all about absorption, and when we do different manipulations, again, even when we are trying to manipulate the joints, we put less pressure to see the tenderness, but in the muscles, we put almost 4 kgs of pressure. But if you're doing the manipulation of the joints, you're putting just 2 kgs. Similarly, the amount of energy that you're directing directly to the joints cannot be the same as what you're directing onto the muscles.
How far away from the skin, and also what's the receptor movement?
So that's a great question. Again, this is all work in progress, as we know. What I've noticed is that a lot of times, depending on the inflammation, there's more sensitivity. Now, as the patient starts to feel really hot in there, you got to back up. My general consensus is that about 6 inches from the source of energy has been quite well worked upon. So again, you've got to adjust the side or the distance from the muscle, but it's typically circular or even direct, because circular, what happens is that, well, we first do some mapping on the face to exactly see where the trigger points are. So you're going to identify those trigger points first, and you do those markings, but as I said, you just don't want to concentrate the energy, so you could do circular movements, or you could do along the path of the muscle fibers. So once you've seen where your trigger points are, when you've done a proper muscle examination, you exactly know where the trigger points are, and you just mark it right there, right on that spot. So there are 2 classes of lasers that I use with physical therapy. One is the LLT, which typically the energy is about 800, 860, and that's what a lot of the physical therapists use. But we're going way step ahead, and we're going beyond 1,000, which is 1,064. So yes, there are consequences. So you've got to be careful how much energy you focus on those tissues, because you're going to cook them. So just like, any complications with LANAP procedures. So you got to be careful of those things. History of LLT. Now this is very interesting. The history goes way back to 1903. So this science is not new. It's been there, but no one has even looked at it. And I wish I had a machine here. I could have, if anyone had a neck pain or any kind of pain, we could actually biostimulate to see the immediate effects. And they work pretty well. So, again, according to the National Library of Medicine, medical subjects having low level of laser therapy, the treatment using irradiation with light or low powered intensities with wavelength in the range of 540 nanometers to 830 nanometers. The physical therapists are primarily used up to a maximum of about 830 nanometers to treat those kind of conditions. And we have gone up on the scale because we have the toy. So yeah, might as well use it. But of course, with good amount of science backing you up on the treatment outcomes. Then again, there's some reference in the journals about photobiomodulation, which is the actual term that needs to get used versus LLT, because there's a lot of vagueness to that terminology. So when I say, are you ready? The fact is that, are you ready mentally? My goal here is to make sure that you understand the science and at least start trying to use it. use it to your effectiveness, and believe it or not, the patients really love it because they see that's the effective way of treating immediate care. I mean, or you prescribe Percocets, Flexerils, that's another choice too. But when patients get immediate relief, it's a huge practice builder for you. That's why I said, you know, the landscapes are changing. People are living in the Amazon world. They want quick, immediate deliveries, next day deliveries. Imagine you are able to relieve pain right then and there. Very useful. All right, so when I say there's more, what I mean is that it's important that we identify these things and not keep doing these things, because, you know, in this patient, every tooth was painful, so every tooth was treated with a root canal treatment. Did I do it? This is not my case, but there are some cases that I've done. And I'm like, okay, stop. It's time to understand what really is the problem. So that's why it's important that we understand what we are treating today. Physical exam setup, pretty simple. We have all these things in our offices. We really don't have to get anything. This is a scale. You can go to Great Lake Orthodontics. They have that, disposables, little examination tools here, tongue depressors, pretty easy stuff. Now, this courtesy UCLA, they use this form every day, daily basis. This is how I record all my data on my patients. So I start recording where the muscles are, the trigger points, the intensity of pain, mild, moderate, severe. So I spend a good half hour to 45 minutes doing a proper TMJ exam so I understand where the problems are. The range of motion, this is really getting into details. I don't want to get into that right now. So, and then there are different calibrations on you know, where the referral is. Sometimes a lot of people come saying, oh, my joint hurts. But it's interesting, a lot of times the pain is actually coming from the shoulder, so it's important to understand where the pain, the origin of the pain is and where it lives. So it's important that you identify those things. Again, muscle palpation. So like, for example, this are some of my markers here, trying to exactly tell them, like, for example, here, the pain is going from the masseter down to the neck joints here, vice versa. The SCMs can be a huge culprit, concentrating pain, and so on and so forth. Another example, now these are trigger points. So if you look at the example I gave you, this is where the pain is, and it shows as if it's in the periauricular area here. It could be on this back side here, like the back muscles here could be showing it up on this direction here. Like the SCMs can start focusing right on the preocular areas here. The masseter muscles could be hurting, the temporal areas could be hurting, so it's important that we identify those sites. And what is a trigger point? It's a small hypersensitive region in the belly of a muscle from which impulses bombard the CNS and gives rise to referred pain. A trigger point is very easy to find. Once you treat it, you'll start to see immediate relief, whether it's on you or your patients. So this is a very good diagram to understand things better. Like, for example, okay, I'm trying to get my laser working here. Okay. The source is here, the digastric. It shows up on your lower anteriors. So obviously, your lower anteriors do not need endodontic procedures. Your source is up on the temporalis, and how many times do we think it's retogenic? We, a lot of times, just focus on those teeth, thinking that it's probably number 14, 15 area, which needs endo. The SCMs, again, same size. The masseters, again, same size. And that's why it's very crucial for us to understand where the pain is coming from, and that's how we treat it. Range of motion. This is a normal range of motion here. We look at any kind of deviations or deflections. And this is another way to interpret as to if it's a pure joint issue or a myofascial issue. The path out here, so I'm going to skip this. Cervical exam. Bite maneuvers. With the tongue depressors, it will confirm whether it's more muscular or more joint related. If it's more joint related, like to answer your question, I'd be very careful focusing the energy on those joints. I'll be backing off a little bit. Then I would do other treatments that probably is indicated in a better way. Again, education, self-management, physical therapy. Radiology is primarily CBCT, if possible, MRIs, anorexis, and professional training, very crucial. And the cartoon says I can't say I'm entirely impressed with my hip replacement. And the reason is that we have the technology out there, but it is important for us to identify those technologies out there and put it to good use and help get our patients better care, and it is absolutely possible. We're going to go with some case presentations, and I'll just end after that. So, as I said, first we're going to interpret what kind of patients are we treating, a psychogenic, a neurogenic, a myogenic. Once we have identified those things, then we have to act accordingly. A psychogenic, good example here. This patient of mine had 20 to 25 drugs the patient was taking every day. Depression, anxiety, connective tissue disorders, diabetes, hypertension. So, laundry list of medications. How can you help such a patient? Well, the patient wanted to have Invisalign done. I said, well, we've got to fix your muscles first. We treated the muscles. The patient, every single time he used to come in, would come in with a severe pain. We would treat him, felt a little relief, come back in a week, treat him again, still relief. So finally, after 6 to 8 months, the patient started to say, I feel much better now. My pain is not as aggravated, and his dependence on medication started to reduce and diminish. And that's a huge plus, because now you know that this thing is working. And on top of that, if he's not dependent on his medications anymore, it's telling us a story there. Had all kind of different medications, as I said, everything there, no sleep, pretty complex. But we got it done. But the most important thing is compliance. And that's what's important, that you make sure that every time the patient comes in, you reinforce physical medicine protocol, better lifestyle, and all that stuff. So there are different things that we were looking at. TMJ, arthralgia, sleep disorders, myofascial pain of the mastication muscles, and movement disorders. They were all there. I was very careful treating that, very joint specific. I wouldn't treat that. I would have the physician treat that. I would look at the range of motions. I would do a few things, and then right after that, we started treating him with some Invisalign. It helped a little bit. And then myofascial pain. The lasers did it for us. So the patient was able to improve his lifestyles. He was able to live better with less pain. Were we able to completely eradicate the pain? Probably not, because it's almost impossible for a patient to follow all the instructions. And those were the real data from the patient, like as we collected. More data. And this was his first visit. I used about 4,197 joules of energy. The second visit, I saw a dip in that because he wasn't complaining of as much pain. So that's why I calibrated the energy to a further lower level. Myogenic patient. Moderate jaw discomfort and tightness. Again, there were no habits recorded. He had previous treatment with some kind of an ENT procedure. The rest of the patient was on Plavix. I had some nasal surgeries done, hypertensive, diabetic. So we really did not do anything complex. Just got the laser out, looked at the trigger points, treated the trigger points, and patients started to get relief. And that was the approach. And as we started to document that, it was just getting better and better. And our approach just started to get better and better. So as I said, we are still, it's a living document, we're still learning. We're learning the science, but we are recording it, and we are actually going to do these studies again with a university-based research program, so we know there's something going on there. This is a third case. The diagnosis again was arthritis confirmed with CT scans. There were movement disorders. We tried this carefully. The patient had some kind of chondroid or cartilage-like growth on their joints. We decided to send it to the oral surgeons to kind of evaluate, and then from there on, the patient went ahead to get a neurosurgeon to look at it. So the goal was to keep it simple, not complicate things. We purely just used the lasers for treating these conditions. We could have thrown different other things in there, like an occlusal guard or some kind of bite adjustments, but we wouldn't know if the laser was working or not. And that's why we just wanted to stick to that protocol strictly. This is my favorite slide today. All the phone addicts today. And why is this important? Is because I'm seeing more and more younger aged patients coming to the office with neck pain and TMJ related pain, because in every degree you bend your neck, the cell phone bend is almost 60 degrees, and it's putting 60 pounds of pressure on your neck muscles. We don't look at our cell phones this way, we are looking at it this way, and that's creating problems. So you start to notice that in your office more frequently. So that's pretty much my presentation for today. Yes?
How would you have a treatment coordinator plan in a case like this? In other words, how many visits, what do they present as far as fees per visit? How do you set expectations, financial expectations for a patient, as well as how, because you might not have it.
That's a great question. So, and the question was, and I'll repeat it, is how do you create like a whole treatment protocol for a patient as far as fees are concerned? But that's going to be the first question. Medical insurances may or may not pay for this kind of a procedure. Maybe a CT scan at the most, I'm not sure. But what I do is I give them a $600 round number. And that would include a full 45-minute comprehensive exam with me and 1 week and every week subsequently for treatment. Some people I've seen charge an office visit fee for every week that they come in. So this way they understand that it's worth $100, $150, so they don't find it overwhelming. Well, the most important thing is once they start to see relief, they're ready to pay. So $600, I cap it at that, and if you put it in numbers, you're looking at about 4 to 6 appointments. Yes? Yeah, that's a tough one. Pterygoids. So inaccessible muscles of the muscles of mastication, the pterygoids are a big problem. I think for the most part, the pterygoids are less vulnerable for symptomatic relief, or in the sense that myofascial pain is more common with masseters and temporalis muscles. So primarily, I would focus on then the pterygoids, of course, then you would start injectables if you can get to them. Exactly, very hard to examine them. Yes?
Do you have any specific consent forms or ADA code that you use?
Well, ADA code, no, but yes, we have consent forms for that procedure, and the consent form approves CT scans, MRIs. I do CTs in my office, not the MRIs, but also the whole treatment protocol. And we explain them ahead of time, and if they have questions, we actually give them to bring with them a pamphlet of information, which would include what is photobiomodulation, the science behind it, the treatment approach, and also we will have an interview with their doctors if necessary, and keep them in the loop as well. Yes?
How often do you do treatments, like the average number of treatments, and like every week?
It depends on the severity of the condition. I had a young girl come in and she was looking for people who would do something like this, and because she did not want to take any medications. She didn't want a Percocet, she didn't want a Flexural, nothing like that. She came in a couple of visits, she was almost completely cured. See, let's understand this. Most of the acute TMDs are self-limiting. They will treat themselves and it'll be fine. But the bottom line is that patients want, like, let's look at aphthous ulcers. 7 days of treatment or not treatment, and patients are going to suffer. But if you use this laser and you treat them then and there, quick, immediate relief. All the patients want is relief. And if you get them in 2 visits, fine. But as I said, if there's more, factors involved in there, there's more like habit issues in there, there's more systemic factors in there, you probably need longer times to treat them. And that's where it's very crucial that you spend a good 45 minutes at least for a comprehensive exam as to what you're trying to treat. Yes?
So with the low-level laser therapy, you focus on the trigger points, not necessarily around the joint.
not necessarily on the joint. Again, if the joint is fine, you don't have to treat the
But if
joint.
you're having maybe some, internal derangement, do you also treat it with a
I would
device,
treat them
or-
step by step. Good question. I would treat the trigger points first, bring some relief, and if it's purely a joint-related issue, then I would look at other options where I look at an occlusal guard, some kind of equilibrations, if necessary, surgery. If really is the only way to go.
Have you seen any direct results treating the joint? And if so, what's the dosage you use for?
If I go very close to the joints, I stick to 1,000 joules. I really don't go more than, I don't know why, but I just want to be safe than sorry. So, but if I'm treating a muscle, a lot of times I can go to 2,000, 3,000 joules, and it's fine. It really is.
Have you seen any adverse effect?
Yes, of course. I've had one patient I treated. The patient had a history of radiation treatment for neck cancer, and I treated, and that nerve just lost it. It started to shoot out severe, intense pain. It just went on the opposite side of the spectrum. So we really had to speak to the neurophysician and kind of manipulate her medications back and again, and that was one of the major adverse effects. So it's, again, as I said, if it's neoplastic, stay away. That's why history is very important. Anything neoplastic or vascular. Migraines, sometimes you could help it a little bit, but if 90% of the times we don't even know if it's a migraine-like condition or not, unless it's truly diagnosed. But yes, if you want to see if it's vascular, if it's neoplastic in origin, stay away from those kind of conditions. Yes, I learned my lesson.
How long are the treatment sessions? Your initial is 45 minutes plus the treatment, and then follow-on visits, or how long?
Follow-up visits are about 15 minutes. And a lot of times I don't even do those follow-up appointments. I just see them. My staff are trained to biostimulate. I'm not even in the room when they're doing it. So of course I say, hi, how are you doing? Kind of briefly speak to them and everything. I calibrate the device. I have the assistants do the biostimulation, which is a good 10 minutes there. So basically my goal is to get 2,000 joules of energy in them. And that was kind of therapeutic. After I spoke to my physicist, we worked on those things. The 2,000 number came up as the most comfortable number without any adverse effects on the tissues. I see other doctors, there are a couple more who use way more than that. But that being said, so once they're done, they call me, I go back and I make some notations on the pain scale as to when you came in, how much was the pain. After they're done with the biostimulation, they wait for a good 15 minutes in the office. And I go back and say, okay, what's the pain scale like and now? So I record once the biostimulation is done, the pain scale, the numbers, and that's 15 minutes after. So we know the progression that's happening there. And honest to God, I have seen great success. And it really works well. And that's why it was important that I thought that this value-added procedure, along with the equipment of doing LANAP and LAPIP, you can use this every day. Every day.
The muscle relaxants you give it, is it like more for an acute problem, or how?
Acute is laser.
Acute is laser.
Yeah.
And the muscle relaxant, would you prescribe that?
I have tried to avoid them because of dependence and other, I try to avoid them.
Okay. So you give what, like a week's worth maybe? Or?
Probably,
Okay.
yes. I'm running out of time. I got a couple of alerts. I apologize, but it's very nice talking to all of you, and I hope good luck going forward. Thank you so much.